Hello, I'm Dr. Daniel Griffin.
And I'm Dixon DePonnier.
And today we're going to be discussing malaria. Now, I think the first thing I will say is this is going to be an executive summary. We're going to be very clinically focused. For those interested in a much broader treatment of this topic, we'll direct you to the full textbook, Parasitic Diseases.
And the video chapter derived from the textbook on this subject.
Exactly. All right. So let's, without further ado, let's talk a little bit about malaria. Malaria is acquired through the bite of a
female anopheline infected mosquito.
Okay. And there are 5 major species of Plasmodium.
There are.
And those would be?
Plasmodium vivax, Plasmodium ovale, Plasmodium malariae, Plasmodium falciparum, and the new addition, the new kid on the block, Plasmodium knowlesi.
Okay. And they've even taken...
Wait a minute, did I get it right?
You did well, you did well. And they've even taken some of these and then realized that maybe there's 2 subspecies within those species. So it gets a little, and the other thing I'll say is we used to always think that it was Plasmodium falciparum that was the major killer, but we're starting to realize that the other malarias are playing a more major role.
The world is a strange place to begin with. And of course, it goes by rumor more or less than by any other thing. So the rumors that come out of the malaria transmission zones are all we have to go on until we've got now a wonderful set of networks that are spread throughout the world. And we can finely tune our perceptions of what's going on. And that's where this information comes from.
Yeah, malaria in many ways is a success story. It's been a huge challenge.
Absolutely.
But we've made some huge strides. We, meaning humanity, has made some huge strides here.
Yes.
Continues to be a major problem. I actually make a point here in saying in 2017 alone, there were 200 million cases and over 400,000 deaths.
That's incredible.
So this is despite the strides, and by the strides, you go back about a decade, and those numbers were double of this.
That's right.
It was 400 million.
That's right.
More than double. It was about 1 million deaths a year.
And we should also say something else here, too. And that is that when they say a death is caused by malaria, that's proven that that patient actually had malaria, they came into a treatment center, and they died. Or they died at home. What about all those people who died from the effects of malaria that allowed something else to happen too? So that's a malaria-related death. And the number that I've heard, I don't know where that number comes from. Is this WHO number?
WHO number.
So I had a friend who spent a year in Ghana, and he was familiar with Nigeria as the next country over, and the number of cases in Nigeria. There are like 65 million people that live in Nigeria. He said every year, everybody in Nigeria gets the infection. Everybody. That's just one country. So you can imagine this is just a huge problem wherever you go throughout the transmission zones, right?
It certainly is. Let's talk about the clinical disease. What is the disease of malaria? The number one presentation, what's the main thing?
It's a fever of unknown origin.
So it is. It's a febrile illness.
Yes.
And what I always say is fever in the tropics is malaria until proven otherwise.
I would absolutely agree with that.
And most clinics will be set up in such a way as where they can make that diagnosis.
Yep.
And so we've talked about the way some of the clinics are set up, where there might be people who are checking patients in, might be then followed by people taking vital signs.
Exactly.
But an interesting issue with malaria is the fever comes in paroxysms.
Doesn't it?
So they might come in saying, I had a fever, it lasts for 6 hours, now I'm okay.
Right.
So who's going to figure out that the patient has a fever? The person checking them in with the chief complaint, or the person checking the vital signs?
Right. When a person actually tells you their fever history, it's probable that they're very familiar with malaria. And they're saying, well, my malaria acted up again, or I've got it again, or something of that sort. So that's part of the hint. But I think, how do you handle that problem?
Well, I think I will say that most of the evidence is that you can trust people.
Okay.
I know I've worked with clinicians who say, oh, if I don't measure it, I don't believe it. But the data's pretty good. People know what a fever is. And if they come in and say, I had a fever for 6 hours, I was laying on the ground, and now I'm okay, or maybe that happened, periodically separated by a certain amount of time.
Yes.
You don't need to have a fever when they're in the clinic for them to be suffering from malaria.
And
so,
no, I was just going to add, and usually it's not just one person. This is epidemic in some cases, endemic in a lot of cases also, but epidemic means that it occurs at a certain time. And there are seasons for this in certain areas. And once you've seen 1 and 10 and then 20, it's likely that everybody else that comes in is suffering from the same thing. Mm-hmm. Wouldn't you agree with that?
There clearly is a seasonality. And I remember I was in Malawi one time, and somebody asked me, when is the rainy season in the United States? When is the rainy season in your country? And I never really think of it that way. I mean, we do have a rainy season.
We do.
We have April showers, spring, May flowers.
This is true.
So the end of our winter, early spring, we do have a rainy season. But in many parts of the world, the rainy season is associated with an increase in malaria.
No question.
And it has a lot to do with an increase in mosquitoes, an
Right.
increase in their lifespan
That's right.
duration. And so you'll often, if you're working in a clinic in an endemic area, you'll see a large percent of malaria during the rainy season, and then during the dry season, it may all but go away.
Correct.
And during, let's say, an area where there's winters
Yes.
and it gets cold, again, when the mosquitoes are not out, you may see your malaria go away.
Indeed.
But I think the first thing is to make the point of it may either be the people doing the vitals who are detecting the febrile illness, or it may be the people doing intake.
Right.
So you may decide when you're setting up your algorithms, your protocols in your clinic, are you gonna, I guess, give rights to either group, the people doing intake, if
Right.
they have a fever history,
Yes.
you may send them right for a smear or a rapid malaria test. If the people doing vitals detect a fever, you may send them for a rapid test.
Yes.
In addition to fever, they may present with chills, may present with shaking, pretty severe chills. They might have headache, fatigue. Abdominal discomfort is a pretty common complaint. And I remember seeing a malaria patient in southern India, and one of the editors of the Oxford Tropical Disease was giving me a hard time because he was saying, Daniel, this individual, they're here for belly pain. Their belly hurts, and you're worried about malaria. So I try to remember that. Maybe their muscles hurt, their belly hurts, their head hurts.
I've heard of backache.
Their back may hurt them.
Yeah.
And the fever, and I think we're going to try to make a distinction, someone who's maybe a returning traveler may have not had the fever start to synchronize.
Right.
And sometimes an acute falciparum malaria may have not had time to start synchronizing, so they may be febrile all the time. They may not have the classic.
Exactly.
So it doesn't have to be this classic 6 hours of fever and then a gap, 6 hours of fever and then another gap.
Right.
Fever, until proven otherwise, is malaria.
That's true.
If you're in the right situation and in
Yes.
the right time of year.
This is true.
But what about the diagnosis? We sort of slipped right into that so very quickly.
Well, it depends on what your facilities have in terms of resources. I think currently we have molecular tests for malaria. So you could do a test for the DNA of the organism and actually find it. But we can also do just a visual identification of the infection as it invades red blood cells. And that's the traditional way that malaria has been diagnosed for as long as there's been microscopes, I guess. And then if you're in some areas that have no equipment whatsoever, but you recognize signs and symptoms, there is one malaria called big spleen disease. It's Plasmodium malariae, which is a piece of cake to identify as long as it's just that and nothing else. So I've heard clinicians that have come back from very remote locations and made that diagnosis based on the fact that they knew there was an epidemic occurring, so that they were fortunate.
Yeah, so this is good. So let's run through the diagnosis. You can base it on signs and symptoms.
Yep.
So this is going to be we'll say a zero technology approach,
Exactly.
which, as we talked early on, this is becoming less and less common because most countries, most areas of the world in general, so even the non-governmental organizations are trying to make malaria something that is confirmed.
Correct.
But let's say you don't have those resources. How might you approach it? So you might have a compatible clinical syndrome. So you might have fever, headache, and then interesting enough, fever, headache, and a palpable spleen is a certain criteria for the clinical diagnosis
That's right.
of probable malaria.
Yep.
And not just malaria, but falciparum,
Yep.
Vivax, Ovale,
All of them.
all of them will, even the acute, will end up with a palpable spleen.
Right.
So that would be your I have no, I'm in the clinical context. The second is when you start moving into your diagnostic tests, and many areas still have our thick and thin blood smears,
Yep.
where we've got a microscope, we've got a trained technician.
Got
They
it.
may be spending as much as 30 minutes per slide.
That's right.
So this can be, I guess, resource
Labor
intensive,
intensive.
labor intensive.
Absolutely.
We have rapid flow testing, much like our pregnancy tests,
Oh. Okay.
where what we're actually doing is putting a little bit of blood into a small part of the test, and then we have a laminar flow where bands will become positive or negative.
I got it.
Not only will these simple RDTs or rapid diagnostic tests for malaria tell you whether or not they have malaria with very good sensitivity very quickly, but they also can tell you which species of malaria.
Nice.
We also, as mentioned, we have nucleic acid amplification testing.
Yes.
And those, I'll say, are used less in a lot of these areas because the laminar flow testing and the microscopy is used in most settings.
That's good.
In the diagnosis is also going to be potentially what species and how severe the infection is. What percent of parasitemia, what percent
Right.
of the red blood cells might be parasitized.
Exactly.
Once we have the diagnosis, then we're going to stage the individual because that's going to help us with therapy. And we're going to make the distinctions really between uncomplicated and complicated or severe malaria. And so for those of you who are watching our list here, and I'm going to run through it for those of you listening in and not watching.
I'm listening to. Trust me.
We might see, and you just really need to have one of these features for it to be considered severe. So you might have a decreased level of consciousness.
Right.
You might be unable to sit or stand without assistance.
Yeah.
You might have a convulsion or a seizure, and actually more than 2 in 24 hours,
Interesting.
right? So I guess you can have 1, that's okay. You could even have 2 maybe. Acidosis, or the bicarbonate dropping down. So we're starting to get into where blood testing is part of the determination. They might have hypoglycemia, and there are specific cutoffs. They might have anemia. So the percentage of red cells may have dropped down.
Right.
They may start to have renal impairment, and people use creatinine and BUN cutoffs. Again, blood test cutoffs for those. They might be visibly jaundiced, which would correspond to a bilirubin greater than 3, or you have a measured bilirubin greater than 3. They might have pulmonary edema. We've talked about this, where you start to hear crackles, usually in the base of the lungs, but you may also see this on imaging if you have the access to a chest x-ray. They may start to have significant bleeding, shock, or the percentage of parasitemia greater than 10%.
Right.
And that's going to guide us right into our different treatments. And treatment has changed a little over time, right?
Yes, quite a bit actually, I think. From the traditional approach of quinine-based medications to today's plant-derived antimalarials and combination therapies and treatment with antibiotics as well. So you're right. And the development of resistance, of course.
Yeah, and I think those are the big topics. So a lot of this will be lookup, people looking at the tables, but the distinction that I want people to remember is you're going to be making a decision between chloroquine sensitive
Right.
and chloroquine resistant.
Exactly.
And this is geographical in certain you're not going to be testing your patient's malaria for sensitivity.
Right.
This is going to be knowledge of where in the world did they potentially acquire the malaria.
Yep.
And when in doubt, you would just assume or treat as if it was chloroquine resistant. If it's complicated, we're going to be thinking about intravenous therapy. And in much of the world, well, as of April 2019, the United States joined the rest of the world in the artemisinin derivatives being the standard of care for acute malaria. There's an interesting story, right, about the artemisinin derivatives?
Very interesting. In fact, they awarded a Nobel Prize to the woman that pioneered that use in China, at least. So the story is that there was a malaria-free zone between Thailand and, I guess it was China, wasn't it?
Yes.
And they wondered what was causing this vacuum of transmission in an area that should have had lots of malaria. And it turned out that people realized that a certain plant contained a curative that they could actually chew on. And much like the cinchona bark derived from Peru for quinine, here was another plant that contained an anti-malarial substance that later on became synthesized after they found out what it was. And now there are many derivatives of it, and some were more potent than others. It's been used enough now so that there's some resistance emerging for some artesunates.
That is true. I mean, the nice thing I'll say about the resistance to the artemisinin derivatives is it may represent a slower response, but I don't think we're really, fortunately,
No
at this
negative
point
response, that's
seeing
right.
complete failures.
Exactly.
We do a percent of the time actually need to retreat because of growing resistance issues.
The difficulty with artemisinin used to be that the plant itself was the source of the drug, and it was harvested from the local environment. And during epidemics or even endemic transmission year-round, they often ran out of the plants, which was a big problem. And now I understand that the plant has been grown in a greenhouse kind of setting in many other places besides where it is found as a native plant. So this will expand the use of artemisinin. And of course, they have synthetic derivatives as well.
So I'll recommend people go ahead and look at the various tables, the various charts we have on the different options, because there's several different options, and it gets a little complicated as far as what option you may want to choose, what option may be available to you, what the right dose might be based upon the age or weight or size of your patient. Right. But there are a couple points that I want to make sure that we throw in. In addition to treating the malaria, about 10% of the time, people with severe malaria will also have bacterial sepsis. So you want to be treating those individuals with broad spectrum antibiotics, which in many parts of the world, as we've discussed, is ceftriaxone. Hypoglycemia can be a major issue for people with malaria, from malaria itself, but also secondary to some of the treatments. So you always want to be keeping an eye on the sugar. Hydration is very important. And then the last, there's a couple of malaria with something, a hypnozoite stage.
Right. So this results from the fact that in this particular case, with both Plasmodium vivax and Plasmodium ovale, the sporozoites that the mosquito introduces into the victim, they all home in on the liver eventually because there are receptor molecules that the sporozoites detect during its circulation. And they penetrate through and into the liver and into the parenchymal cells. And ordinarily, if it wasn't either of those two species, some of those sporozoites would go on to reproduce into the stage that eventually gets into the blood. But these two have a special little trick up their sleeve. They can delay maturation. And so you can have an initial burst of the infection. You get better, you think you're cured, of course. 2 years later, you're out of the malaria zone, you get another attack of malaria. What the heck is that all about? And then another year after that, you get another attack of malaria. These are the sporozoites that have become dormant and then reemerged as an infection sometime later on down the road. And these little stages are called hypnozoites.
So if you are worried about the hypnozoites, there is one drug that we've been using for many years now called Primaquine. This you need to actually dose for 2 weeks. There's a newer agent that I'm not sure is ready for prime time, is actually in development, so this may expand. There may be a second drug eventually.
Oh.
But you do want to test your patient ahead of time for G6PD deficiency, which is an enzymatic deficiency where if they have that, and it actually protects against malaria, so you may see this in patients in these areas where they really can't take the Primaquine because they'll actually have lysis of their red cells.
Right.
But so think about that. If you're worried about Vivax and Ovali, they may have a hypnozoite stage. You get them all better, you think it's all good. If you don't clear the hypnozoite stage, you may see malaria come back again.
A relapse, that's right.
All right. Well, there's a lot to malaria. There's issues about people going to areas, wanting not to get it. There's bed nets, there's medicine you might take. But if you want to know more, please feel free to go to Parasites Without Borders.
You bet.
Read more in the textbook.
Yep.
And watch a more extensive video on malaria. All right. Thank you for joining us today.
Yeah, we'll see you again soon.